This is part 2 of 2 for the cardiovascular system, blood. In this video, we'll be discussing disorders of erythrocytes and types of anemia, white blood cells, blood clotting, and blood types. The term anemia refers to the fact that there's either not enough hemoglobin in the red blood cells circulating in the blood, or there's not enough properly formed red blood cells in the bloodstream. And it's really not a disease, it's more of a symptom. And there are three main causes of anemia, one of which is blood loss. Blood loss can occur whenever there are major wounds, lesions, or ulcers, or even hemorrhoids, inflammation of the stomach, and even some cancers can cause a loss of blood. In fact, years ago, when nonsteroidal anti-inflammatory drugs came out, elderly people were popping them like M&Ms to relieve the pain of arthritis. And these people were actually hemorrhaging internally because the nonsteroidal anti-inflammatories were preventing cells in their stomach from protecting their stomach against the stomach acid. And so they were hemorrhaging internally and didn't even realize it. They would go to the hospital, and that's when this would be discovered. So blood loss is one reason that anemia can occur. Another reason anemia can potentially occur is whenever there could be either a decrease in the production of red blood cells, or if they're not produced properly, so faulty production or decreased production of erythrocytes. And then thirdly, if there is excessive destruction of those red blood cells, that could potentially lead to anemia. This picture on this slide represents that your fist is approximately equal to a volume of 500 milliliters of fluid, just to give you an idea. And then the representation of different fractures throughout the body or a cut on the surface of the leg also give you an idea of how much blood loss might occur should those injuries be present. Sickle cell anemia is a type of anemia that occurs when the red blood cells, instead of having properly produced hemoglobin, have an abnormal type of hemoglobin called hemoglobin S. Remember that our genetic information, our DNA, contains instructions on how to build proteins. And when these proteins aren't built properly, which is the case in sickle cell anemia, then the function's not going to occur normally. And in a normal erythrocyte, the shape of the hemoglobin allows that little red blood cell to fold in on itself as it's squeezing through capillaries, which are the tiniest blood vessels in the body. With sickle cell anemia, the red blood cell takes on a sickle shape. It's a curved shape, and that's because there's an abnormal hemoglobin called hemoglobin S. And again, this is a genetic disorder because our genes have the instructions on how to build proteins. If the protein's not built properly, it won't have its proper function. This hemoglobin S causes the erythrocytes to take on that curved sickle shape, and that causes the erythrocytes to block the blood flow as it's going through the tissues. This leads to a variety of problems, including painful joints, delayed growth, blindness can occur sometimes, as well as cerebrovascular accidents. And this is a genetic disorder that can occur in African Americans. Iron deficiency anemia is the most common type of anemia that can occur because oftentimes people are not getting enough iron in their diet, and when the available amount of iron is not sufficient to produce properly functioning heme groups, that can lead to iron deficiency anemia. And this is a problem that can be found in children, teens, adults as well. and vegetarians and vegans, and can be caused either by an inability to absorb and transport iron or slow chronic bleeding. Usually people have an insufficient intake of iron, and when we look at available iron in the diet, there are two forms of iron that are available. There's heme iron in animal-based foods like meats and eggs, and non-heme iron, which is found in plant-based forms of iron that people would find in spinach. So the best way for a person to absorb iron, whether it's heme or non-heme, is to combine that food with some form of vitamin C. Maybe make sure that an orange is included or some grapefruit is included with that particular meal where the person's trying to absorb more iron, because we normally only absorb about 20% of the iron in the food that we eat. And if there's not enough iron in the body and iron deficiency anemia starts to occur, that can lead to a whole host of problems, which you can see listed on this slide. Things like feeling lethargic or fatigue, even depression, headaches, insomnia, pruritus, which is itching, or shortness of breath, chest pains. So there's a whole host of problems that can occur with iron deficiency anemia. Iron deficiency anemia is sometimes referred to as microcytic anemia because the erythrocytes that are produced are generally very tiny and very pale. However, with vitamin deficient anemias, we see the opposite occurring. Vitamin deficient anemias generally involve vitamin B12 and folate, which is also known as B9. And this causes what we refer to as megaloblastic anemia. Megaloblastic anemia is a form of macrocytic anemia. So instead of tiny cells, we've got really big cells. And macrocytic anemia is a blood disorder that happens when the bone marrow starts producing stem cells that make really large reticulocytes. And these reticulocytes, many of them are too large to go into the bloodstream to carry oxygen. And whenever there's a lack of meat or some kind of alternate source or insufficient vegetables that lead to a lack of vitamin B12 or a lack of B9, megaloblastic anemia can occur. There are other causes of this, and I'm going to talk about those as well. Now, pernicious anemia is a type of megaloblastic anemia that's specifically caused by that lack of intrinsic factor that's commonly seen in people who have Crohn's disease, which is an autoimmune disorder where the body attacks the lining of the intestines, and that may lead to surgical removal of that part of the intestines. This can also be a result of stomach surgeries where a portion of the stomach has been removed, or it can be as a result of intestinal parasites, or sometimes even with acquired immune deficiency syndrome, which is AIDS. Now, pregnancies and some medications, alcohol consumption when it's abused, and those are other things that can lead to these vitamin deficiency or megaloblastic anemias. However, know that there can be several causes of megaloblastic anemia, and when we specifically talk about pernicious anemia, that's usually because of the lack of intrinsic factor in the intestines caused by Crohn's or some kind of stomach surgery or something to do with the intestines or acquired immune deficiency syndrome. Pernicious anemia is a much more specific type of megaloblastic anemia. Aplastic anemia is a rare type of anemia that occurs when the stem cells in bone marrow are damaged, which would lead to a decrease in not only erythrocytes, but also leukocytes, which are white blood cells, and platelets, which are broken up pieces of thrombocytes. And this is often triggered by radiation, medications, chemotherapy, or sometimes even infections or viruses. And it can also be inherited, but this is a very, very severe type of anemia. Thalassemia is a term that literally translated means sea blood, not sea as in I see you or si senor. It's sea as in ocean. And it's typically something that occurs in people of Mediterranean ancestry, such as Greeks, Italians, can also be found in Africans, Southeast Asians. And what happens with thalassemia is one of the globin chains in hemoglobin is either absent or faulty, and that leads to the erythrocytes becoming very thin, very delicate, and deficient in hemoglobin. There are a lot of different subtypes in thalassemia, and they're classified according to which hemoglobin chain is affected and where. Thalassemia can range in severity from very mild to severe, and symptoms often include things like fatigue, weakness, paleness, slow growth. The milder forms of thalassemia may not even need treatment, but severe forms require sometimes a donor stem cell transport or monthly blood transfusions. They can be that severe. Polycythemia is a condition where an excessive number of erythrocytes is being produced, and that makes the blood thicker. And that increase in viscosity is going to make it harder for the heart to push the blood, and that increases blood pressure as well as causing the heart to have to work harder to pump blood through. And there are conditions that can cause polycythemia to occur, such as dehydration or living at a higher altitude. And those conditions may be temporary or transient unless somebody moves to a higher altitude and stays there for a while. But in the case of living in a higher altitude, that reduced atmospheric pressure and lower oxygen content can cause red blood cell counts to increase to 6 to 8 million cells per microliter, where they would normally be at about 4.5 million cells per microliter. In the case of dehydration, usually just having more hydration can solve that problem. There is, however, a condition known as polycythemia vera, which is a bone marrow cancer characterized by dizziness and an extremely high red blood cell count of anywhere from 8 to 11 million erythrocytes per microliter, and that can cause a lot of problems because the vascular system just can't move that blood through, and oftentimes they have to withdraw blood and replace it with saline just to help dilute the blood in the bloodstream. And with the increase in viscosity not only causing an elevated blood pressure, that can sometimes also lead to other conditions known as thrombosis, which is condition of a blood clot. A thrombus is a blood clot, and gout is another secondary consequence sometimes of polycythemia. Sometimes athletes will artificially induce polycythemia by going up into a higher elevation to exercise, where their bodies, with that increased demand for oxygen and the higher altitude will produce more red blood cells, at which point they will have those red blood cells withdrawn from their body, store them, and then re-inject them right before a competition. And blood doping is highly frowned upon in most athletic competitions. Next, we're going to discuss white blood cells, or leukocytes. These are the only formed elements, which you remember are red blood cells, white blood cells, and platelets, which are complete cells, and they can actually move. They move by a way of one of two processes. One process is called diapedesis, where they can actually move through the cells that make up the wall of a capillary, so they can go out of capillaries. And another way that they move is by way of positive chemotaxis, where they're actually moving in response to chemicals that are released. And there are different types of white blood cells. We have granular leukocytes and agranular leukocytes. The granular leukocytes, if you remember the name Ben, basophils, eosinophils, and neutrophils, have granules within their cytoplasm that are more easily seen when they're stained and you're looking at them under the microscope. Agranular leukocytes include monocytes and lymphocytes, and even though those cells have granules, they are fewer in number and they don't really show up very easily when you look at them under the microscope, so they appear agranular. When you look at this picture, you can see a process of what happens in terms of a response to tissue damage. In this case, at the top picture, you see that there are injured and infected cells that are secreting chemical signals into the bloodstream. And in response, the leukocytes in the blood are going to respond to the chemicals that are released by the damaged cells, and they're going to leave the blood vessel in which they're circulating, and as they squeeze through those capillary walls, they're going to continue to follow the chemical signal that's attracting them to the area that's damaged, and that's what we call positive chemotaxis. So we had the diapedesis occur when they moved through the capillary wall, and then we have the positive chemotaxis by those cells further going towards the damaged area. And then finally, we see that within the damaged tissue, some of those white blood cells, the monocytes, are going to turn into or differentiate into macrophages. Those are the big eaters that are going to eat up the pathogens. And there are also, in this particular picture, eosinophils and neutrophils that are going to release chemicals that help to break down the pathogens. And they're also capable of phagocytosis. This takes us to a really cool chart of the lineage of leukocytes. Remember that with red blood cells, we start with a hematopoietic stem cell that becomes a more committed cell. That committed cell actually goes through a specific pathway of development, and we didn't really discuss that. And then finally, as part of that development, it becomes a reticulocyte, which is an immature red blood cell, and then finally an erythrocyte. When we look at the lineage of leukocytes, again, we start with hematopoietic stem cells, also known as hemocytoblasts. And as those undergo mitosis, some of them will differentiate into either what are known as myeloid stem cells, while others will differentiate into what are called lymphoid stem cells. The lymphoid stem cells will further differentiate into committed cells known as B and T lymphocyte precursors, and then they'll eventually become either B lymphocytes or T lymphocytes. Now, some of those B lymphocytes can become special cells called plasma cells. We'll discuss what they do a little bit later. And some of the T lymphocytes will also differentiate into what are known as effector T cells. When we look at the very top of the chart again, going back to the hematopoietic stem cell or hemocytoblast, you'll see that when those cells divide, they also might turn into what are known as myeloid stem cells. Myeloid stem cells further differentiate into committed cells. Those committed cells go through a developmental pathway and eventually turn into either granular leukocytes or monocytes. Those granular leukocytes include eosinophils, basophils, and neutrophils, whereas the monocyte, which is agranular, will either stay as a monocyte or some of those will further differentiate into macrophages. The next granular leukocyte we're going to look at is the eosinophil. Eosinophils actually got their name because they soak up a special stain called eosin really nicely and turn this kind of orangey color in which you can really see the granules well. Eosinophils only make up between 2 and 4% of the total white blood cell count, and we use the number 2 with the mnemonic below, which, if you've noticed, is a different mnemonic. You can use never let Mikey eat bagels or never let my engine blow. Obviously the N stands for neutrophils, and the E in either mnemonic is going to stand for the eosinophil. Eosinophils have maybe 2 to 3 lobes in their nuclei, and the granules that they produce actually contain antihistamine molecules that will respond to inflammation. Remember that when cells are damaged, they release histamine and heparin as part of their inflammatory response. Eosinophils also contain granules that are toxic to parasitic worms, and they are phagocytic as well. They will especially eat up antibody-antigen complexes. When antibodies are produced in response to an antigen, those two molecules will bind together, forming a complex, and eosinophils are some of the white blood cells that will be involved in eating those up. We see elevated eosinophil counts when a person is experiencing allergies, may have a parasitic infection, or be dealing with an autoimmune disease. Again, never let my engine blow is going to be another mnemonic of the white blood cell count average for each type of white blood cell from highest to lowest. So we go 60, 30, 80, 2, less than 1. The last of the 3 types of granular leukocytes are basophils. Basophils are the smallest as well of the granular leukocytes, and they make up less than 1% of the total count. They generally have a nucleus that only has 2 lobes at most, and because they soak up a stain that is basic or alkaline, they tend to stain a darker blue. The granules contained in basophils actually enhance an inflammatory response. Similar to mast cells, they will also release histamine and heparin when there is an inflammatory response. If we look at this particular mnemonic, never let Mikey eat bagels, bagels stands for basophils, or never let my engine blow, the B stands for basophil, which is less than 1% of the total white blood cell count. When it comes to agranular leukocytes, we have lymphocytes and monocytes. Lymphocytes are a part of the lineage from lymphoid stem cells, whereas monocytes come from myeloid stem cells. In this particular slide, we're going to look at lymphocytes. Lymphocytes are going to make up approximately 30% of all leukocytes if we follow our mnemonic at the bottom of the slide. Never let my engine blow. You'll see that let has the value of 30% assigned to it, or never let Mikey eat bagels. It would be the same thing. The percentages stay the same with these mnemonics. I just gave you both mnemonics to see which one you prefer. In terms of the immune response that lymphocytes participate in, there are different types of lymphocytes with different roles. We have natural killer lymphocytes, sometimes referred to as natural killer cells, B lymphocytes, T lymphocytes, and memory lymphocytes, sometimes referred to as plasma cells. If there are too many lymphocytes, if there's an elevated count, then that could potentially indicate a viral infection or even cancer. If there's not enough, it could be due to a chronic illness or some kind of immunosuppression process that's going on. Agranular leukocytes include monocytes and lymphocytes. Monocytes come from the myeloid stem cell line. And if we look at our mnemonic below that says never let Mikey eat bagels, or if you prefer never let my engine blow, the M stands for monocytes. So about 8% of all white blood cells are monocytes. Under the microscope, these appear very large. They have kind of a pale blue cytoplasm with a kidney bean shaped or horseshoe shaped nucleus. And once monocytes exit the bloodstream to work their way through surrounding tissue, they differentiate into macrophages. Macrophages will eat up any kind of pathogens or debris or worn out cells, and they also release chemicals for the process of chemotaxis, which helps call in other white blood cells to that particular area. If there is an elevated count of monocytes and a white blood cell count, that could potentially indicate either a viral or fungal infection, possibly leukemia, possibly tuberculosis. And if there's not enough monocytes in a white blood cell count, that could potentially indicate suppression of bone marrow. When we look at disorders of leukocytes, the condition of leukopenia basically means that there are not enough white blood cells being produced. And leukocytosis is a condition of having too many white blood cells, but when there's too many, they're often not functioning properly. Leukemia means that there is a cancer that involves non- or malfunctioning white blood cells that are overabundant. Basically, cancer causes too many cells to be produced, but they don't differentiate in the types of cells that they're supposed to be, hence the non-function. Lymphoma is a cancer where there are actually malignant T and B lymphocytes that could potentially accumulate in the spleen, in the liver, and other tissues. Platelets come from myeloid stem cells in the bone marrow. In the presence of thrombopoietin, myeloid stem cells can differentiate into megakaryoblast, which will further differentiate into megakaryocytes. Megakaryocytes develop tiny little cytoplasmic extensions which will try to poke through capillary walls in the bone marrow. When they try to poke through the capillary walls, as they go through, they rupture into anywhere between 2,000 and 3,000 pieces per cell. These platelets, which are the fragments, will then circulate through the bloodstream, and about a third of them will set up house in the spleen where they can remain there for storage until they're needed, at which point they would become active. If they're not needed, then they would simply be eaten up by macrophages. Platelets play a really important role in hemostasis. which literally translated means blood halting. Let's take a look at that process in the next slide. Before we talk about the process of clotting, let's consider a blood vessel. Blood vessels have an innermost wall or lining known as the endothelium. That layer is surrounded by areolar connective tissue, which is surrounded by a layer of smooth muscle, which in turn is surrounded by more connective tissue. Normally, cells in the innermost lining, the endothelium, produce and secrete nitric oxide and prostacyclin, which help the flow of blood because they prevent platelets from clumping together in normal situations. However, when there's damage to a blood vessel, three things occur: vascular spasm, the formation of a platelet plug, and coagulation. Let's take a look at this process. When a blood vessel is damaged or severed, the irritation to the smooth muscle that surrounds the blood vessel is going to cause that area to undergo spasm. That's the vascular spasm. Vascular spasm is most effective in small blood vessels, and it's going to be at that local area where there was damage. That spasm can last anywhere between 20 and 30 minutes and is going to help decrease the flow of blood because the area of the opening is going to be smaller, and that helps to slow down blood loss. When that blood vessel is severed, not only is there a reflexive spasm from the smooth muscle, but other things are going to happen. Because we now have blood and plasma leaking out of that blood vessel into the surrounding tissue, when large plasma proteins known as von Willebrand factor come in contact with the damaged endothelium and the underlying collagen fibers of the areolar connective tissue, that activates those large proteins and causes them to help build a bridge between the underlying collagen and platelets in the blood. The von Willebrand factor also causes those platelets to swell, to develop little spikes, and to become stickier. And as those platelets start to aggregate together, they start to form a platelet plug, becoming stickier and more numerous. And as those platelets cling together, they release chemicals inside of them, including adenosine diphosphate, which causes more platelets to come into the area and release their contents, and serotonin and thromboxane A, which will further increase the spasm of the blood vessel and further enhance that aggregation of platelets. So the formation of a platelet plug only takes approximately a minute to occur. However, the platelet plug that forms is fairly loose, and we need to have something that's going to bind it together really well. This is where coagulation comes in. With coagulation, there are two different pathways that converge together to form a final common pathway. If you look at the picture on the right-hand side, you'll notice there's an intrinsic pathway and an extrinsic pathway. And at some point towards the bottom, they converge together to form that final common pathway. Now, you'll notice that these pathways include clotting factors, which are basically plasma proteins, different plasma proteins. And when damage occurs, it causes certain factors to become activated, and in turn, those activated factors will activate other plasma proteins. So it's a series of enzymes that are working in a cascade of chemical reactions until they finally join together for that final common pathway. So you can see where at the end of the intrinsic pathway and the extrinsic pathway, the intrinsic being damage to the vessel wall and the extrinsic referring to the response from cells outside of the blood vessel, you'll notice that they form a complex of enzymes that will activate yet another plasma protein. That number 10 is actually a special protein called Stewart factor, and Stewart factor, when activated, will activate another plasma protein called proaccelerin. Don't get tied up in these names, just know that it's basically an enzyme activating another protein enzyme activating another protein enzyme. This is where it's important. That final common pathway where the plasma protein prothrombin, in the presence of the proaccelerin, which is the number 5, gets converted into thrombin. And then when thrombin becomes activated and formed, that helps convert a soluble plasma protein known as fibrinogen into insoluble fibrin. And then fibrin, in conjunction with fibrin stabilizing factor, which is that last turquoise spiky oval that you see in this chart, they're going to together not only produce fibers, but also stabilize those fibers. And those collagen fibers, in the process of coagulation, are what knit everything together to help stop the bleeding. So even though I've explained that whole thing, what I really wanted for you to understand was kind of like the process. Why doesn't blood normally clot? And then the 3 things that happen when there's damage: the vascular spasm, the formation of the platelet plug, and then coagulation. And then getting an understanding of all these different plasma proteins working in conjunction together until we get to the final common pathway, knowing that we go from prothrombin to thrombin, which converts fibrinogen into fibrin. So normally fibrinogen is a plasma protein that circulates in the blood, but it is soluble, which means it's floating around there and it's pretty much dissolved in the plasma. It's not until thrombin becomes activated that fibrinogen gets converted into fibrin, which needs that stabilizing factor in order for it to be a good solid fiber to help knit everything together. So that is coagulation. This slide shows what happens when there's a problem with platelets. The term thrombocytosis means that there are too many platelets, and that can cause unwanted blood clots. In the slide, you can actually see all those dark little bluish spots are platelets. And understand that sometimes platelets are referred to as thrombocytes, even though they're not cells. They're fragments of cells known as megakaryocytes. So please understand, thrombocytosis, too many platelets, can cause clotting when we don't want it. Now, the opposite of that is thrombocytopenia, and that means that there's an insufficient number of platelets and blood is not able to clot properly. That can lead to a condition known as petechia. In this particular slide, we see the plural form of that word, petechiae, and purpura. So petechia are tiny little pinpoint purplish bruises, right? They're tiny little pinpoint bruise spots. Purpura is going to be larger and much easier to see from further away. And if blood can't clot properly, that can be a real big problem. Sometimes this condition can be caused by an autoimmune problem where the body is attacking the megakaryocytes so that they can't be produced properly. Clotting mechanisms can fail sometimes. Hemophilia is an example of what can occur when the body is unable to produce clotting factors. That could be due to the fact that the clotting factors that you saw in the earlier slide are proteins, and we know that genes, which are segments of DNA that have the instructions on how to build a specific protein, are important for that process. So if there's a problem with the genetic sequence, that could lead to a clotting factor in that entire cascade to not work properly, and it just takes one of those enzymes to not work properly to cause a problem in the cascade. And depending on where it falls within that cascade, it could either be really bad or not too bad, but it can still affect the body. Hemophilia can also be caused by certain drugs. Blood thinners like Coumadin and warfarin can cause hemophilia. The term thrombosis simply means that it's a condition of excessive clot formation. A thrombus is the term for a clot, and usually when a clot occurs, it's where not only is there an aggregation of platelets, white blood cells, red blood cells, and fibrin strands can also block and damage blood vessels. An embolus is a thrombus that breaks off and can travel to other areas. So a thrombus by itself is just a blood clot that's stuck, but if a thrombus becomes dislodged and starts moving, then it's termed an embolus. Or if a piece of that thrombus breaks off and starts moving, it's termed an embolus. And that can be a real problem. That could travel to the brain and cause an ischemic stroke, or it could go to the lungs and rupture and cause bleeding within the lungs. On this particular slide, we've got a great piece of information about deep vein thrombosis. So deep vein thrombosis can occur if a thrombus develops in a deep vein, and usually that's going to be in the legs, but it can also occur in the pelvis or sometimes in the arms, and it can lead to complete blockage of circulation, which can cause very, very big problems. Usually if somebody's got deep vein thrombosis, that person's going to have pain in that local area. It'll be warm and tender and swollen and red. And with deep vein thrombosis, sometimes that part of the clot can break away and become an embolus. Again, if it goes to the lungs, it becomes a pulmonary embolus, and pulmonary embolism is potentially life-threatening. So this is just a nice little piece of information on deep vein thrombosis. Before we get into blood cell typing, let's go over a few quick terms. Antigens are basically things that the body does not recognize as belonging to it or being of self-origin. And so antigens will trigger a defensive response from the immune system. Because the markers on the surfaces of red blood cells are large glycoproteins, sometimes, more specifically, antigens may be referred to as agglutinogens or agglutins. However, on this chart, we see the term antigen. Antibodies are plasma proteins that are produced by B lymphocytes that will stick to and help to flag or mark antigens as necessary to be destroyed. Agglutination occurs when antibodies and antigens come together and form that lock and key combination by sticking together. It's pretty much a receptor ligand combination. Remember, the term ligand is just a fancy term for a molecule. So if my A antigen, right, is round and I have an antibody that fits that shape, then they can form an antigen-antibody complex, and now they're stuck together, and that causes agglutination. So let's take a closer look at this chart. We see that a red blood cell type A has specific A antigens on its plasma membrane. You can see just that one single little A antigen if you go 2 blocks below that red blood cell. And then we also see just between those 2 blocks, there's anti-B antibodies in the plasma. Remember, the antibodies are going to circulate in the blood, in the plasma, and they're designed to fight not A blood cells, because we want those to be viable, but they'll actually go after B's. That's why with type A blood, we have antibodies that are anti-B antibodies. And then if we look at the very bottom of that red blood cell type A, in the event of an emergency, a person with type A blood can receive type A or an emergency type O. And this is why, even though type O blood has type anti-A and anti-B antibodies, it won't cause all of the blood to agglutinate or stick together. And that's why O is considered a universal donor. If we look at type B blood, you'll see that there's a different shape for that glycoprotein marker. And you can see that type B blood will have protein antibodies in the plasma that are anti-A antibodies. Type B blood can receive type B or type O. When we look at AB blood, we see that there are both types of markers on the plasma membrane of the red blood cell, and therefore there are no antibodies in the plasma. There are A and B antigens on the surface of the red blood cell, but no antibodies in the plasma. And so AB can receive any kind of blood. It's known as the universal recipient. And then finally, type O blood, again, has anti-A and anti-B antibodies, but it has no glycoprotein markers on its surface. And that's why O is referred to as the universal donor, because nothing can fight against it. It's got no markers on its surface. It will survive. There is yet another type of glycoprotein marker on the surface of red blood cells known as Rh factor. Rh factor was named after the rhesus monkey. It's R-H-E-S-U-S, and that's how it got its name. And there have been over 52 types of rhesus factors identified. However, I think C, D, and E are the most common. You don't have to know those letters. However, rhesus factor is important because if a person has that factor on the surfaces of his red blood cells, then that person is determined to be Rh positive. Without that factor, then the person would be Rh negative. So if you've ever heard A positive, A negative, B positive, B negative, AB positive, AB negative, O positive, O negative, then they're including that Rh factor. Now, Rh factor is really important to understand because If a man and a woman who are not of the same Rh factor, and especially if the woman is negative and the man is positive, if that woman were to become pregnant, then in that first pregnancy, her body will build up a sensitivity. As blood is exchanged between the mom and the baby, the positive Rh blood in the baby from the father will start affecting the mom's body, and she can become sensitized. Now, her body won't attack the baby and the baby's red blood cells in that first pregnancy, but it could be a problem for future pregnancies. So usually if a woman is Rh negative and the father is Rh positive, what they'll do is during pregnancy and after delivery, they'll give mom a shot of something called RhoGAM, which helps prevent her body from producing a response, an immune response against the baby's blood, because it can actually cause hemolysis after that first baby is delivered. If she doesn't get the RhoGAM, it can cause hemolysis in future babies, and that's why they do that. So if we look at, universal donors and universal recipients and add the Rh factor, the true universal donor is going to be O negative because there's no A, B, or Rh antigens present, so there won't be any immune response that can be elicited. With a universal recipient, AB positive is the universal recipient because that person's blood has everything. It's got the A, B, and Rh antigens, which again are the surface markers, so it won't reject any type of blood transfusion. And that ends blood.